Leichliter. Welcome to the March Talk with the Doc. We're joined by Dr. Timothy Leichliter of Allegheny Health Network for our monthly Talk with the Doc session. Thank you as always. Christine Haythorne is here as well, our CEO and Executive Director. We'll share a few announcements in the end about upcoming programs and events, especially our conference. But for now, let's talk with the doc, and I will hand it over to our one in charge, Dr. Leichliter.
In charge is a bit of a stretch, but I can't wait to hear the updates. Well, so I'm Dr. Leichliter. Welcome everybody back to Talk with the Doc. So this is a great place to answer questions that you might have. I always go over a couple of things here, which is, this is a great general information spot. So this is not a great place to get individualized treatment. I would suggest talking to your doctor, going over specifics with them to figure out a good treatment strategy for you. I generally like to think that I give you as much scientific data as I can find or as I know, but sometimes I just have to make stuff up, and I tell you I'm going to make stuff up. Yeah, the end. There's probably other caveats that I throw out there, but I'll remember them as I do. I got a lot of questions in email, so I got my chamomile tea here, so it's like tea time with me. And I'll see if we can get through as many of these questions as possible. Casey's right. The best place to, if you have more questions, is to type them in the chat box. And then after I go through my emails here, I'll start there and we'll see what we can do here. All right. I'm bothered by frequent biting of my lower lip, which is often quite painful because my chewing is pretty hard. I occasionally bite my inside of my cheek and tongue. How can I minimize these painful occurrences? So that's not an uncommon thing that I hear. I do get people who have either bite their tongue or bite their cheek, and sometimes it's due to dyskinesia. So when you have the medications overshoot, sometimes you get kind of squirmy movements or extra movements, and you can get it in your tongue as well. And sometimes that leads to difficulty with control of eating or chewing. I have also had patients where they get jaw and tongue tremors, which would kind of be the opposite end of the spectrum. Maybe you need a little bit more medicine, but that can also lead to coordinated issue and biting of your tongue or biting of your cheek and things like that. So there's actually a couple of different things that I hear not infrequently or uncommonly that lead to that type of a problem. And much like is a common theme with these talks or in my office, trying to get as much information about it as you can is the best way to work on it. Does it happen when you're due for your next dose of medicine? Does it happen when your medicine is kicked in and you have extra movements elsewhere? Does it have nothing to do with the medicines? Do you have dentures that don't fit properly? Is that what's causing the problem? Is this more of a oral maxillofacial or a dental issue? So trying to pinpoint all of those things is hard, don't get me wrong, but probably the best way to figure out what can be done about it. So again, it's not an uncommon thing that I hear, but trying to get to the root of it is really the best way to try to figure out what to do about it. Then I got a question regarding Parkinson's disease and seizures. Is this a common occurrence later in the stage of Parkinson's disease? Why does it happen? So-and-so they began having seizures. So Parkinson's disease and seizures, it's tough to say if one causes the other, but at the end of the day, these are two very common things. And so you're going to run into overlap with them. And so it's not uncommon for people with Parkinson's disease, because it's a relatively common condition, to also sometimes have seizures, which is another relatively common condition. One could potentially lead to the other. So you can get seizures just by the aging brain. And so as your brain ages, you do get some changes. You can get some shrinkage of the brain, which can affect the cortex, which is the outer part of the brain. And anything that irritates that outer part of the brain, even if it's just normal aging or shrinkage, or if you have a stroke or a vascular event, that can lead to a seizure. And since aging is also the #1 risk factor for Parkinson's disease, again, there's going to be some overlap there. I do have a handful of my Parkinson's disease patients that have seizures. I wouldn't say that it's tremendously common. The vast majority of my patients do not, but there's definitely some overlap there. And then you just treat them separately as such. At least that's the way that I do it. My husband drools a lot. What can we do to make it stop? It's pretty heavy. So again, drooling and hypersaliva and secretions is another common thing that I get, common question that I get, common thing that I see in my office. And it happens for a lot of reasons. Not only do you have extra secretions, but you tend to sit with your mouth open, and so that tends to make them thicker. You also tend to be flexed forward or head down, and gravity works, and so things tend to come out. I also hear a lot about running nose, watery eyes, things like that. And it's part of the Parkinson's disease process. Now, no, not everybody gets this, but it's common enough that it does go with it. There's a couple of things you can do. Again, there's no great solution for something like this. There are a couple of things that I try. There are pills that you can take, things like glycopyrrolate, scopolamine patch. You do have to worry about kind of thinking or brain fog or confusion with some of these medicines. And so my preferred method for treating it is injections. So botulinum toxin injections into the salivary glands, the parotid gland here and the submandibular gland here. I've actually had fairly good, not perfect, but fairly good success treating drooling in that regard. I prefer MyoBlock. That's just one of the 4 commercially available botulinum toxins because that's what I've had the best success with. Maybe that's what I learned on. I can't remember. That was a while ago. But Botox and Xeomin are also approved for this, and I've had pretty good success with all 3 of these types of injections. And so realistically, if it is that bad, or if it really is impacting quality of life, because believe me, I hear a lot, people don't like to go out. They don't want to go out to eat. They have to take a towel with them everywhere they go. I hear all of these things. So if it really is impacting quality of life, it's worth not ignoring. It's worth doing something about. And so injections are probably what I've had the best success with in that regard. I've heard this, there must have been some information about this recently, because I've heard this question be asked quite a few times recently, which is, do statins exacerbate Parkinson's symptoms? And the short answer is, I don't know. So there have been a couple of looks at statins, and this is Lipitor and Zocor and, all the ORs. And they're used for cholesterol and stroke prevention and heart attacks and things like that. And so they're used commonly. And there's been some conflicting data about the statins. So there's been some data to suggest that they are helpful, particularly certain types of statins, because statins come in water and non-water philic. And then there's been some data that suggests that statins actually increase the progression of Parkinson's disease. And so my personal opinion is that the data is iffy. It's conflicting. It's not obvious one way or another. And so I really don't say one way or another on statin therapy. Again, statins are useful, right? If we're talking about preventing a heart attack or a stroke, well, hey, that's a great idea. And so if your primary care doctor, or if your cardiologist, or if your doctor thinks you need to be on a statin for those types of prevention, I don't think there's enough data in the Parkinson's disease world to say, no, you should not. And likewise, I also don't think there's enough data to say, okay, your cholesterol's fine, you don't have any risk factors here, you should take a statin because it's protective in Parkinson's disease. And so my short answer on the statin idea is it's too soon to tell. We need some more information before we can really try to answer that question. And as it comes, we'll have more information. But for now, I think statin therapy used in the appropriate person for cholesterol management, for vascular risk factors, is okay, even in Parkinson's disease. And I wouldn't do anything different otherwise. How much does anxiety play into triggering Parkinson's symptoms? And do you recommend involving a psychiatrist to be part of the team? Yes and yes. So anxiety is huge. So not only is anxiety and depression very, very, very common in people with Parkinson's disease, depression's listed statistically as 50% if you read the literature. My personal opinion is it's probably much, much higher than that. Anxiety is also probably much, much higher than that. Those are my personal opinions, because I see them all the time. Sometimes I can handle it. Sometimes I can handle it through a variety of things, medications, meditation, breathing, things like that. Mindfulness, great. And yes, they always amplify symptoms, particularly tremors. Everybody who shakes, if you're anxious, if you're upset, if you're nervous, if you're agitated, you're going to shake more. It can also affect the other motor symptoms. It can affect the walking and balance and things like that. Freezing of gait is huge in the anxiety component. And so all of the symptoms can be impacted by anxiety. And the short answer to the second question is yes, I recommend psychiatry and psychology all the time to patients. Now, if I can handle it, if I can do something, and I'm not a very good psychiatrist, I'll be the first person to tell you this. And I would also argue that your primary care doctor is probably not a great psychiatrist, even though sometimes they think they are. But if it's straightforward enough that I can treat it, or I can get you to relatively calm, it's not necessarily impacting day-to-day life, then no, you don't need a psychiatrist or a psychologist. But if it really is, it's common enough, it's amplifying your symptoms enough, it's impacting your day-to-day life enough, it's keeping you from doing things, then we absolutely need a psychiatrist and a psychologist. They are the people who do this the best. They have the best handle on all the interventions, on medications, on transcranial magnetic stimulation, or whatever else is out there. Plus, they also do a lot of cognitive behavioral therapy, which is huge from an anxiety standpoint. And so, yes, I oftentimes refer patients to psychiatry and psychology. Now, almost across the board, when I recommend somebody see a psychiatrist, they're like, oh, I don't want to go to a psychiatrist. I'm not a crazy person. Bad philosophy. Believe it or not, psychiatrists are the best people for even things as simple as anxiety and depression. And I put simple in quotation marks because, believe me, it is not often simple. And so we need to get past the stigma of going to a psychiatrist or a psychologist, because they are very, very helpful for managing some of these problems. And they are the best people and the most qualified people to handle anxiety and depression. I try, PCPs try, but we are not nearly as good as they are at doing it. So if I refer you to a psychiatrist, it's not because I think you're a crazy person. It's because you have anxiety or you have depression or you have something that I am trying, but not the best person to handle. And there is somebody better than me who can help us. So yes, I often involve them as part of the team. And this was actually a comment more than a question, but I actually used this today, so I'll read it to everybody else. I was having a lot of trouble using a computer mouse because my tremor would accidentally cause my fingers to click the mouse buttons. The use of a vertical mouse has nearly eliminated this problem. The vertical mouse causes the hand to rotate 90 degrees, so the hand rests on the little finger in the handshake position, rather than having the hand in the pronated position. So I had a tremor patient today who was having trouble using the computer, so I told him about this. I don't know. I don't know that anybody's ever necessarily told me that, but it does make sense. Positioning definitely plays a role in your tremor, as everybody here probably knows. And I do get a lot of people that, because of their tremor, they kind of double or triple, quadruple click things and difficulty maneuvering a mouse. So maybe that's actually a good, more adaptation to a disability than a fix. But I thought that was very interesting, and I already told somebody about it today, so take that for what it's worth. All right, I'm having a big issue with freezing. I currently fall on an average of 15 times per day. I've injured myself a number of times, fractured some things. I currently take a couple of medicines multiple times per day. Should I take them on an empty stomach or with food is ultimately the question, but I think there's a lot more to this question than meets the eye. So the short answer is particularly with levodopa, it works best on an empty stomach. So protein, in particularly large amino acids, can compete for the carrier protein that gets it from your stomach to the brain. And so if you just imagine a train going by and there's only so many cars, if you fill up those cars with proteins or other amino acids, you're not going to have room for levodopa. Now, it's subjective. I have plenty of patients that do not notice a problem eating when they take their medicine. And it really comes down to how much genetically you have of this carrier protein. If you're somebody that's been blessed with infinity amount of this carrier protein, you can eat with your pills and it'll still work. You won't notice a difference. If you're somebody who is unfortunately blessed with a short train that does not have a lot of this carrier protein, then there's going to be significant competition. And you may notice that if you eat particularly things with protein, your pills are not going to work. And it's because you don't get them absorbed via that carrier protein. So the short answer to the question is yes, medications work best on an empty stomach. Now, they also tend to cause more side effects on an empty stomach, particularly upset stomach or nausea. And eating does help with that. And so what I usually tell my patients is it's trial and error. If you find that they're not as effective when you take them with food, try them on an empty stomach. If you tolerate your pills on an empty stomach, they do work best that way, go for it. But in regards to the rest of that question, freezing of gait is tough because medications are not always the answer for freezing of gait. You know, we do use carbidopa, levodopa, and pramipexole, and amantadine, and you'll see me use off-the-wall things. I'll use dementia medicines like Exelon. I'll use a stimulant like methylphenidate. I will pick and choose seemingly random medications because maybe they have a little bit of data somewhere to suggest they help with freezing of gait. Because at the end of the day, freezing of gait is extremely difficult to treat with medications. Doesn't respond to deep brain stimulator surgery great, although maybe a little bit, and is a problem because it very, very, very often leads to falling, and falling is the most dangerous problem. That's the number one thing that lands my patients in the hospital. And so it's extremely important to work on, but it's very challenging to work on. Most of the time, physical therapy, cueing. So this is where the cue from Europe would be potentially beneficial if it ever makes it to this country. This is with the neck stride or the laser line or a metronome or things that can, music, talk therapy, counting. These are probably the things that work the best for freezing. And this is where therapy comes in play. They practice that. They have you work on that. But realistically, even if you took all your medicines on an empty stomach, I'm not entirely sure they're going to fix or solve the freezing of gait issue or the falling issue. And so that's a big challenge. Yes, definitely try it on an empty stomach if you're not already, because maybe if the medicines are a little bit more effective, they will help. The medicines do help some, but freezing of gait is a notoriously difficult problem that we sometimes have to think outside of the box for from a medication standpoint. And very, very, very often we refer to physical therapy, occupational therapy, working on this cueing, kind of other things to see if we can help. Because if you're falling 15 times per day, we are really in trouble. That is a surefire way to end up in the hospital and have bad things happen. And so that needs to be attacked, addressed, worked on in any fashion pretty much as soon as possible. I simultaneously like and don't like this next question because you're not going to like my answer, and it's the answer I'm going to stick with. He's not going to like my answer, and it's the answer I'm going to stick with. So my husband was diagnosed with Parkinson's about 2 years ago, and we noticed symptoms the year prior. He had been there's been some driving issues. They thought he was unsafe when he was driving. Somebody had him take the adaptive driving test through PIT, and he failed. So they took away his license. And I promise you, the number one thing that we do as neurologists that really piss people off or anger people is take away a license. And we recognize that, by the way. Believe me, we don't do it because it's fun for us. We don't do it because it's easy and it's not a big deal. Believe me, we definitely think hard before we take away somebody's license. Obviously, he's mad about this, right? And so he had to surrender his license. He said the test was rigged against him. All he talks about is wanting to drive again. He wants to get his permit and go through Rogers Driving School, somewhere other than adaptive driving. He doesn't trust them. Obviously, the family's at fault. They're to blame. It was their fault. They pretty much took away his license. I'm sure you've heard all of these things, so on and so forth. There's also some other issues, but that's the long and short of it. And so, what do we do about this? Because driving is such an important tool for getting out of the house, for going to therapy, which I recommend, for getting to the gym and exercising like I tell you about. And yet, we know with Parkinson's disease, again, reaction time slows down. Tremor and stiffness oftentimes interfere with, going from gas to brake, turning the steering wheel. Thinking gets slow, right? Decision-making gets slow. And all of these things play a role in driving. Now, a lot of my patients with Parkinson's disease still drive. Believe me, I am not out here stripping everybody of their license, but there comes times where usually it's significant others or family or children or friends come and say, you know what, I'm not entirely sure he should still be or she should still be driving. And this is how I handle it, very much how they handled it for you. And I'm going to get to that in a second, which is, again, if everybody involved agrees you can drive, okay, you can drive. My office is not set up to evaluate you for the ability to drive. I am not set up in the clinic to test your reflexes, test your thinking in a manner that would suggest you can or can't drive. I'm not the best person to figure that out in my office. And so if everybody agrees, if you come in and you say you can drive and your family comes in and says, no, he's a pretty safe driver, we're fine with it, fine, you can drive. And vice versa, right? If you don't think you can drive, if your family doesn't think you can drive, if your neighbor doesn't think you can drive, then you shouldn't be driving. That one's kind of a no-brainer. Obviously, the problem comes in when the patients think they can drive and somebody else doesn't, either because there's been an accident or they think there's issues or there's question marks. And so, believe me, I don't like to be the bad guy either. And so I say, you know what? You probably shouldn't drive. Again, significant others, family, friends, they're usually pretty good indicators of your driving abilities. But if you really want to prove that you can, go take an on-the-road test. That's how I solve the problem. I say, if you pass an on-the-road test, I will absolutely tooth and nail fight your family and let you drive. So I'm in my 10th year now of doing this. I have probably only sent maybe a dozen people for an on-the-road test. Usually through talking, we come to a conclusion that everybody agrees on. But I would say maybe a dozen people I've sent for an on-the-road test. And my pass rate is 0%. 0. I have never once sent a person for an on-the-road test because somebody told me they didn't think they could drive and they passed. Not a one. And I'm going to give you a hint. It's not because the test was rigged against you or that the test is so overly difficult that nobody can pass. It's because significant others and kids and family and friends are pretty good indicators that you should not be driving. And so you are more than welcome to go try to get your permit and go to another driving school and pass a driver's test. But that's been my experience, is that by the time other people are really, because believe me, your family is not eager to strip you of your freedoms. Your significant other does not have it in for you. Your kids do not have, a vendetta against you. They really don't think you're safe driving. And by the time other people have noticed that you're probably not a safe driver, you probably should have stopped driving couple years ago, believe it or not, by the time they bring it up. And so I wouldn't tell you can't do it, but my experience has been just that, where I really think the likelihood of you passing is going to be very, very low. And it's not because the tests are stacked against you. It's because you really shouldn't be driving. Other people are good at picking it up. And so that's how I handle it in my clinic. So if you were my patient, I would tell you that. That's how I always handle driving. Again, as long as there's a consensus, it's not a big deal and we don't have to worry about it. But when there's not, I often refer to the driving schools. My husband has not had a tetanus booster shot for over 10 years and was recommended to get one now. He has advanced Parkinson's disease. Should he be concerned about side effects or get it without worry? I mean, I can never say you should get it without worry, but yeah, at the end of the day, if that's what's recommended, you should get it. And that's just true for every vaccine known to man. Yes, I have heard my patients complain to me about issues with the COVID vaccine, with RSV, with flu shots. I can't remember tetanus shot offhand, but probably at some point. I'll throw that one in quotation marks. But at the end of the day, I have heard complaints and issues about every vaccine that I can think of. And yet I still think they're good. At the end of the day, believe me, what they are solving or what they are treating is significantly worse. Yes, there's a risk to everything. I don't disagree with that. And if you've had an issue with a vaccine and you don't want to get it, I'm not going to force you to. But at the end of the day, when people ask me, should I get this vaccine? My PCP wants me to do this. This is what's recommended. Unless there's a really good reason to say, no, you shouldn't, I generally go with what they say. Is it possible that I'm over-medicating myself, since for at least an hour after taking the carbidopa, levodopa, and Mirapex, I have more movement than I would like or think I should have? Yes, is the short answer. So it sounds like those are dyskinesias, and that is often a side effect of the medication. It doesn't mean that you're necessarily overdosing yourself or taking too much medicine. You may very well need that much medicine to be less stiff and less slow and more mobile. But if it is a problem, if you're noticing extra movements and it's bothersome, then yes, that could be a side effect of the medicine, and decreasing the medicine may help with that. Now, decreasing the medicine may make you stiffer and slower, and so we do have to find this balance of potential difficulties, but that's kind of the short answer to that question. And I like how, Casey, you said this was the last question, and then it was not indeed the last question. Thank you for that. Is there a connection between peripheral neuropathy and Parkinson's disease? No doubt that there is, but wanted to know for sure. And the short answer is yes and no. Again, coming back to a similar thing to seizures in Parkinson's disease, neuropathy is even more common than that. And so with things being common things overlap with common things. Now, there is a connection in the Cinemet world. So not necessarily with regular carbidopa, levodopa, but in the intestinal infusion levodopa, peripheral neuropathy was a side effect. I don't know how to wrap my head around that necessarily. I can't necessarily explain that, but we know there is a connection there potentially between the medications and peripheral neuropathy. And for those of you who don't know, peripheral neuropathy is usually numbness and tingling in your fingertips or toes. It can be electrical, it can be burning, and usually it kind of works its way up. That's the classic presentation of peripheral neuropathy. And so I do think there's probably a connection there between Parkinson's disease, the medications, and neuropathy. But again, common things being common, it's not outside of the realm of possibility that you were just lucky enough to get both. And I would treat them as I would treat each of them individually, except for in the same person. But you do have to be careful because peripheral neuropathy also leads to walking and balance problems, particularly if you're in the dark or you close your eyes. Because you can't feel your feet on the floor, you rely heavily on your vision to stay upright. And so you really have to be careful if you're washing your hair or face in the shower, you got to be holding on. Or if you get up in the middle of the night to go to the bathroom or for whatever reason, there have to be night lights everywhere. So if your vision is obscured because you close your eyes or because it's dark, you're going to be at a much higher risk of falling. And so you should at least be aware of that. I thought this question was interesting. Regarding insomnia, sleep, and dreams, is there any information about if acting out dreams or vivid dreams are a result of getting back some sleep after a bout of insomnia? People blame it on the medications they may prescribe to fix insomnia, but it could also be a brain finally get to do what it couldn't do when it finally gets some sleep, and it tries to make up for the loss. I thought that was a really interesting take on it. Or could it also both be medicines and returning to sleep causing acting out dreams? So acting out dreams or REM behavior sleep disorder is actually a side effect of Parkinson's disease. Even before medications, even before insomnia, you can get acting out dreams, vivid dreams. It's part of the dopamine pathway, and it's one of the non-motor symptoms that I often ask about that predate the tremors and the stiffness and the slowness of movement, sometimes by many years. And so acting out dreams is actually a side effect of the disease. Yes, I do often find that it is amplified when I put people on Cinemed or dopamine medicines. That tends to make the vivid dreams worse. They're not always bad. In fact, I would argue that most of the time they are not nightmares. They are not bad. They are just very vivid. People dream about old colleagues or work or things that happened in the past. But that is usually, in my opinion, more a side effect of the disease with amplification of the medicines. I like the idea about insomnia, and is that your brain just trying to make up for lack of sleep? I mean, there might be some logic there. And you can get some of these issues with things like Zolpidem or Ambien. They can give you acting out or sleepwalking or different types of sleep problems. But realistically, a lot of my patients have talking in their sleep, and that's usually more a side effect of the disease than the medications. And I'm not sure it's related to your brain catching up in sleep after insomnia, but I like that idea. There might be something to it. All right. I think that was all the ones that you sent me in email. So that was a lot. Now I'll go back to the top here and see what I can come up with here. Hopefully everybody's still with me. My tea's not cold yet. I don't understand the first question. So does Nupro last something?
There's a additional comment, like
Oh, okay. 2 down. See? Thank you, Casey.
You're welcome.
Can Nupro patch last longer than 24 hours? Yes, but no. If I were giving an actual FDA talk, I would say no. We think of it as a 24-hour medicine, but I think, and this is a little bit in my memory from years back, but I think even in the studies, it lasted up to 36 hours. Now, again, Nupro is the patch that we use. It's a dopamine agonist. This is for ticotine. I like it for smoothing out ups and downs and covering nighttime. It theoretically is a 24-hour patch, so you're supposed to change it every day, roughly around the same time. But if I remember correctly, and you'd have to fact check me, I believe in the study or in a study of pharmacokinetics, it did last up to 36 hours. But at the end of the day, you should probably change it every 24 hours. That's how long it's supposed to or intended to last, and that's probably the best way to get the most effect out of it. Can exercise improve motor function with PD? Now, everybody is expecting me to say yes to this question because exercise is indeed my favorite topic. And of course, I'm going to say yes, but there's always a caveat. I never give you guys a straight answer. That's just not in my nature. And where's the fun in that? Yes, with time, exercise definitely improves motor function. Now, how does it do that? It's not a great tremor medicine. In fact, what I was going to say is a lot of my patients tell me that after intense exercise, they feel worse. They shake more, they have more walking problems. But in the long run, it does. So either through strengthening your muscles or working on your mechanics or your posture or your balance, it definitively has the power to improve motor function over time. But that's a double-edged sword because, again, early on when you're exhausted, you overexert yourself, that can actually amplify your symptoms. And so I prefer exercise. It's my favorite thing to talk about because it's potentially disease modifying, but exercise is a long game plan. I don't think exercise is your best acute treatment strategy. It's not going to take away your tremor. It's not going to fix your stiffness like the pills do or theoretically do, but it's still the best thing for you long term because of the impacts that it has not only on your body and your mechanics, but the underlying brain condition itself. And so that even though I know you were expecting just a simple yes out of me, you're never going to get just a simple yes out of me. That's a little bit more complicated, but yes, you should be exercising because it does help everything. Listening from a brother who is a patient of mine. Thanks. Welcome to the party. Parkinson's disease does not run in our family. What other things like toxic environments can cause it? So Parkinson's disease we don't know what causes Parkinson's disease. Let me start there. We have not unraveled all of the ins and outs and the secrets of Parkinson's disease by any means. In fact, I would argue we're still a ways away from understanding it very well. Probably somewhere around 10 to 15% of Parkinson's disease is directly genetic. Now, that number's iffy. If you would have asked me that 10 years ago, it was probably closer to 5 to 10. If you ask me that in 10 years, it'll probably be closer to 20 to 30, maybe. The more we learn about genetics, the more we find, the more genes we find, the more mutations we find, the higher that number gets. Likewise, there are definitely some environmental things that we're fairly confident trigger Parkinson's disease, and things that come to mind are Agent Orange. So people who were over in Vietnam exposed to Agent Orange have a significantly higher chance of developing, amongst other things, Parkinson's disease. Manganese toxicity. So there was a study and they looked at this in manganese miners down in South America who had extensive exposure to manganese, and they ended up with Parkinsonism. Industrial strength pesticides. So everybody heard about Roundup. There was a big lawsuit, kind of nationwide lawsuit about Roundup, but farmers in particular, ones who spray their crops with a lot of chemicals, tended to develop Parkinson's disease more frequently. Now, the vast majority of my patients are not Vietnam vets, they're not industrial farmers, they're not manganese miners. And so does that mean that it's not a toxicity thing? No, of course not. Probably the thing written about the most more recently is trichloroethylene, which is a degreaser or a chemical that's found in a whole lot of things. There's a lot more being written about things like that. But again, these are incidental things. I think the grander picture is that yes, we know environmental factors trigger Parkinson's disease. And the other argument I would use is I can't tell you how many times I've seen a patient and they say, you know what? 6 people on my street growing up all have Parkinson's disease. Every single person that I worked with in the mill now has Parkinson's disease. I mean, these aren't just chances. Yes, genetics plays a role, but again, environment has to be playing a role in this too. And so the short answer is we think it's a combination of your genetic predisposition with some sort of environmental triggers that adds up through some Swiss cheese model or whatever other kind of model they're talking about these days to end up giving you Parkinson's symptoms. Because of that, not only are we hard at figuring out, okay, what triggered it in this person, but everybody has something a little bit different. Everybody's genetic composition and environmental triggers is a little bit different that ends them up having the same symptoms. And because of that, it makes it really hard to fix. It's very hard to fix things when multiple different pathways or multiple different things all look exactly the same in the end. And I think this exact problem is why we're not exactly all that good at fixing it just yet. I really think we have to delve into individual genetic issues, individual, environmental triggers, and try to piece together what causes what so we can better target or attack the underlying problem. Now, that was a much longer-winded answer than you were probably looking for, but the short answer is yes, that we're learning more and more about the environmental triggers. So I find myself asking more and more, hey, what did you used to do for work? What kind of exposures were there? Were there any toxic chemicals where you were working? I'm starting to I can't do anything about it yet. I don't have any actual impact that I can make based on the information, but I am starting to ask more because we're learning more and more about how it leads to either the beginning or the progression or the symptoms of Parkinson's disease. Is leg shaking / tremor common during exercise? Yep. So again, exercise in the short term can definitely make motor symptoms worse. I have a lot of patients that come back and say, when I exercise, I shake more. I shake all over my arms, my legs, my trunk. Especially if you're pushing it, you're doing intensive exercise, but even for some people just walking down the street. But it's the long-term gain that we're talking about in exercise that really makes it that helpful. And so the short answer to your question is yes, tremors and other increased symptoms are common during exercise, and you just have to kind of work through it. Sometimes you try to schedule medicine. You can either take more medicine around that time or schedule the timing of your medicine for when you're going to exercise. Again, my patients do a lot of different things with or without my consent. And you just have to figure out what works better for you. Have I seen daily periodicity in some symptoms such as fatigue and tremulousness? And the short answer to that is yes, there are definitely patterns. Everybody develops their own pattern. So I hear a lot, hey, the mornings are bad for me. I can't get started. It takes me a while to get moving. But by the time the afternoon hits, we get moving, I feel better. Or exactly the opposite of that. I feel great when I first wake up in the morning. But man, as the day progresses, I get tired and everything gets worse. And everybody finds their own patterns through the day. The one very, very common pattern that I see all the time is afternoon, sometime between 2 and 5. That tends to be a really bad time for just about everybody. Now, I had learned back in the day, and this was hearsay, I never did actually fact check this, that is the time people naturally make the least amount of dopamine. I've never actually looked into that to see if it is the case, but at the end of the day, that is a common theme that I hear. So a lot of people need a nap in the early afternoon or into the early evening. That tends to be a downtime, and that's just what I hear commonly. That's just a pattern that I've noticed. Is it a fact? I don't know. But I do hear patterns in periods, these kind of fluctuations in a lot of people. And so I think there is something to it. That's an interesting question. Has there been any discussion into weight, height, men, women on dosage of levodopa? Not that I'm aware of. Now, in terms of a study or a discussion for that matter, in my practice, it's all trial and error. So I'm fairly unless there's an extenuating circumstances, like and not to be ageist here, but if I have 100-year-old, or if I have somebody who weighs 75 pounds, or if I have somebody, not any of you, but if I have somebody who is old and frail, then I might use a lower dose, a 10/100 carbidopa levodopa. But almost across the board, I use the 25/100. I get you on 2 or 3 times a day, and we adjust from there. And so while I don't know that anybody's actually looked at, hey, should we start different dosages based on height, weight, male, female, every single person here knows that what we start with is just a jumping off point anyway. Everything we do thereafter is based on what happens with our starting point. And so I'm fairly in my world, this isn't me. I don't know. I forgot the caveat at the beginning is that what you're getting is all my opinions. You may go down the street to somebody else or across the country to somebody else, and they may have very, very different opinions, but everything you're getting is my opinion. I have a fairly standardized way that I start medicines just out of habit and success, I guess. And then once I get you on that medicine, if you tell me it's too much, I go down on it. If you have side effects, but it helps, then I back it down to the lower dose. If it's not enough, I go higher. And so I don't know that I necessarily base the dosing adjustment on any physical characteristics. I think I base it on response. And I don't know that in my personal experience that I've noticed a specific pattern that, hey, men tend to need more, women tend to need less, or vice versa. Or, hey, I got this 600-pound person and they needed a huge amount, whereas this 150-pound person didn't, or vice versa. I don't know that I've necessarily noticed a pattern in my clinic. And so I don't know that there's been any study or discussion into it. But I would argue that it also doesn't matter because we're ultimately going to adjust and change and do different things based on the end result symptomatically, not based on physical characteristics. Can I start a B1 clinical trial? I mean, maybe, but who's going to fund it? And this is a common theme, right? So for those of you who don't know, there's some data out there that suggests high doses of B1 are good for people with Parkinson's disease. And I'm not going to lie, I've had patients come back and say, you know what, I do feel better. I'm less shaky. I have more energy. My walking is better. I have started having that experience. But in my opinion, there's not enough hard and fast clinical data or clinical trial data for me to recommend it to everybody. And this is a common theme for supplements, over-the-counter things. devices. It's really hard to get gold standard trials, right? So for those of you who don't know, a gold standard trial in the medical world is a double-blinded, placebo-controlled, randomized trial. What that means is we have some people get the drug and some people get a very similar looking thing but has sugar in it. And neither you nor I know what you're getting until the very end. And we randomize that. And then there's somebody who is open, who knows the answer, who has it in a paper or on a locked computer somewhere, and they analyze the data when all is said and done. That is the best way to minimize bias, because again, and if you've looked at any studies recently in Parkinson's disease, there is a huge placebo effect. On the order of 20 to 30% of people that get sugar pills get better. And so that is a huge thing in research world, where you really want to show that the drug does indeed work, not because the person was excited about it or thought it was going to work or expected it to work, but because it actually works. And you do that by comparing it to people who also think they may be getting the drug, and you make sure that there's a difference. That's really expensive. It costs a whole lot of money to do a trial like that. And so that's why you don't see those kind of trials in vitamins, in supplements, in over-the-counter things, in alternative medicines, because again, it's a business and people want to make sure they're making back their money, end of story. And they're not going to make back their money by proving that B1 is helpful, unless you own B1, but nobody does. It's a vitamin. And so I wouldn't be against doing a clinical trial on it. I wouldn't be against being at least a part of it. Believe me, I have plenty of patients who would be interested in participating. And I know the Parkinson's Foundation is doing a kind of a patient-led experience for it. And I'm hearing feedback that's actually pretty good. But at the end of the day, without a clinical trial, without good evidence, it's really hard for me to recommend. And so the short answer is if somebody can fund it and they can come up with the trial and they're looking for people to be a part of it, send me a message. I will tell you that I've had a hard time getting stuff pushed through my research department, but doesn't mean we can't try. What is my opinion of deep brain stimulation? When does it work best? I like deep brain stimulation. So let's start with what is deep brain stimulation. So deep brain stimulation is exactly what it sounds like. We're stimulating deep in the brain. So we've been doing DBS for 20 plus years. We do it here at Allegheny General. They do it over at UPMC. They do it at most major academic centers in the country. And it's aggressive. Okay, so we drill holes into your skull. We put wires into your brain. We hook you up to a generator in your chest, all internal. And we electrically block signals that lead to the symptoms of Parkinson's disease, essential tremor, dystonia. They're looking at an obesity that we just actually implanted here, our first case for opioid abuse disorder. And so they're looking at it a whole bunch of things. I'll focus on Parkinson's disease. And we've had really good success with it for the past 20 plus years. We have two very skilled surgeons here who do a great job in conjunction with us in the Movement Disorder Center. And we've been doing this for a long time. So I like it. That's my overall opinion of it. Is it perfect? No. Is it curative? No. Is it a good treatment option in the correct person? Yes. And so that's how I view it. Much like medications are a good treatment option in the correct patient, DBS is a good treatment option in the correct patient. I personally think it works best for certain symptoms and less good for some of the other symptoms. It works for all symptoms, but it works better for things like tremors and stiffness and less good for things like walking and balance, much like the medications. And so my opinion is that if you take your best on time, the best you feel when your medicines are kicking in, that's what we're aiming for with DBS. If your medicines are not fixing your freezing of gait or your walking, I am hard pressed thinking that DBS is going to fix your freezing of gait or walking. But if your walking and balance problems gets better when your medicines are kicked in and worse when they wear off, DBS might help with that too. Now, yes, I think it works better for tremor and stiffness, but it does have some effect on all of these things. And then, so who is the right person for it? So the right person, the ideal person, is somebody who's younger. Nothing against older people, but the The older you are, usually the more medical problems you potentially have, and the worse as an overall surgical candidate you are. So a younger person with tremor predominant Parkinson's disease, and yes, specifically Parkinson's disease, not one of the other atypical Parkinsonisms, because it's much less effective for that, with good response to medicine, because again, it works best for the same things that medicines work with, but either somebody who we've increased medicines or we've added a couple different things and they've had side effects or they aren't getting the benefit we were hoping, and we want to do something more aggressive. That would be the ideal person. Now, obviously, the ideal person doesn't walk into my office all that often. And so we do have to pick and choose what we're looking for. But arguably, if you've had the disease for a couple of years so that we're confident in the diagnosis, and again, particularly tremors, but really any of your symptoms that are medication responsive to, and you've tried a couple of medicines, we haven't had as much success as we would like, or you're starting to have medication side effects or problems, that's when we start thinking about DBS. And that's when I start having you think about it. I would argue it probably takes a good year from the first time that I mention it, where I say, hey, what do you think about this? Or, hey, have we ever talked about surgery? Before patients come around and say, okay, I think I'm ready. It is not something that I say, hey, what do you think about brain surgery? And you're like, yep, sign me up for that. That sounds like a great plan. That is not how it works. There is a lot of thought, a lot of planning that goes into deep brain stimulation. And there's some hoops you have to jump through as well. There's memory testing, there's on-off testing, there's MRI. There are some other things that we have to do. But I like to bring it up when we start having problems with medicines. You've had it for a couple of years. Medicines aren't doing what we had hoped or not as good, or you're needing more and more. That's when I start planting the seed to say, hey, what do you know about DBS? Have we ever talked about it? I'm not suggesting we get you to the surgeons just yet, although they would definitely want me to get you there sooner rather than later. But start thinking about it, because I think we're going to talk about it more. And so as I see you month after month or every few months or whatever, we start talking about it more until we come to that conclusion. That's how it usually works in the office, and that's what I would expect. But that's my general thought about DBS. I do like it. We've had a lot of good success. But again, it's another tool to use in the correct person. The end. What are the advantages or drawbacks of DBS? Well, the advantages are that oftentimes, not always, but oftentimes we are able to cut back medications. It's not the goal. My goal of surgery is not to fix you. It's not to cure you. It's not to take you off of your medicines. My goal of surgery is to get you feeling better. If that means I can back down on your medicines, great. If I can't and you need all your medicines and stimulation, I'm okay with that too. If you need more medicine to go along with the stimulation, if that's what it takes to get you doing better, that's what we're going to do. Oftentimes we are able to cut back medicines. And it's adjustable. So as symptoms increase, we can sometimes play with the different settings and adjust things. Now, there are some drawbacks. It's brain surgery. Again, now, if there was such a thing as easy brain surgery, in my opinion, this would be it. But there is no such thing as easy brain surgery. That doesn't exist. This is still brain surgery. Now, again, the statistics are low, but they're never zero. And so these are things that the surgeons would talk to you about. What are the risks? What are the potential complications? There are also some drawbacks to the stimulation itself. So what I typically see in my patients is that we diagnose you with Parkinson's disease, and then we ramp up your medicines to a point, and then we say, hey, what do you think about surgery? And then we do surgery. And we increase the stimulation and we go down on the medicines. But over time, what I find is that we tend to run into some problems the higher you go on the stimulation, either some vision problems or some speech problems, or maybe some balance problems. And then we kind of back down on the stimulation and we go back up on the medication, and we try to find this happy middle ground. Now, that everything that I just said is about 5 to 10 years in about 20 seconds. But at the end of the day, that's the pattern that I commonly see. And again, I don't want somebody going to surgery saying, this is going to fix me, this is going to get me off of my medicine. The goal of surgery is not that. The goal of surgery is to help control your symptoms so that you can do all the stuff I want you to do, like exercise and be active and get out of your house and go socialize. That really is the goal. And most times it's a combination of stimulation and medications. Yes, surgery comes with potential side effects and problems, but it also comes with potential benefits. What are the benefits of selegiline? So selegiline is a medicine that we use in Parkinson's disease. It's an old monoamine oxidase inhibitor type B, which means it's brain specific, as opposed to the old-fashioned antidepressants that were not brain specific and you had to be on a special diet and you couldn't take anything else. Selegiline can interact with other medicines, but you don't have to be on a special diet for it. But there's a couple of reasons why I use selegiline, or why I will try selegiline. One, it's definitely not one of my first go-tos. It's an older drug. Rasagiline I probably use more than selegiline. It's once a day, not twice a day. Generally better tolerated. But the one time I probably do go to selegiline is when blood pressure is involved. So most of the medications that we use for Parkinson's disease tend to lower your blood pressure. Now, for people who have high blood pressure, that's not a big problem. A lot of times as the disease progresses or as the medications progress, you're able to come down on your medicines to lower blood pressure and potentially get off of them. But in a lot of my patients, autonomic insufficiency or autonomic problems come with Parkinson's disease. And so they can actually have too low of blood pressure. And so then you can think, okay, if carbidopa, levodopa lowers blood pressure, I'm treating your physical symptoms, but if you get lightheaded and dizzy every time you stand up, that's not exactly a win. Selegiline breaks down into an amphetamine derivative. And so at the end of the day, it's one of the few medicines that I have for Parkinson's disease that is at least blood pressure neutral, if not a little bit boosting. It's not great, believe me. I've had plenty of patients where I tried it, and it does not increase their blood pressure. They still get lightheaded, dizzy. We still got to go to Midodrine or Florinef or the other medicines. But that's probably the one time you'll see me use it the most, is when I'm trying not to lower blood pressure further, or I'm trying to increase blood pressure a little bit. That's probably the time you'll see me use selegiline the most. Again, it does help. It helps. So monoamine oxidase breaks down dopamine. And so the idea is if you inhibit that, then you keep dopamine around longer. That's the whole purpose of that class of medicine. And so it does help with Parkinson's symptoms, but there are other ways to do that. And so that's why that's the one situation you'll see me use selegiline. So cueing, I believe, is Cueing for future reference, like cue, like I'm taking a cue. I don't know if I use that in any way, shape, or form correct, but I believe it is CUE, not just the letter Q. Have I had patients that experience severe stimulation-induced dyskinesia and sudden onset of anxiety as a result of DBS programming? Yeah, I mean, you can get all things happening when you're programming DBS. So for those of you who've had DBS, we're a little bit better at it now. Some people use the computer recommended or generated stuff. Some people still do it the old-fashioned way. But yes, and so for those of you not in the know or don't have wires sticking into your brain, generally when we're trying to figure out initial settings, we basically take contact by contact, because there's 4 different contacts on each wire that's in your brain, and we kind of turn up the volume, so to speak. And then if we run it, if we get benefit, great, we make a note of that. If we run into problems, we make a note of that. We turn that one back down, we go up to the next one, we turn that one up, turn it off, go, and so on and so forth. So we try each and every contact to figure out which one gives us the best success. And yes, I have seen people that when we are adjusting that, they are not too fond of us because it jolts them, or they get dyskinetic, or they get significantly rigid. I've seen pretty much just about everything especially with initial programming. Now you can get it with adjustments too, because if you tweak too far, or if you stimulate something too much, it can definitely give you issues. And so at the end of the day, that none of that really surprises me. I'm not the one doing DBS adjustments anymore. I have a nurse practitioner who does it. We've had nurse practitioners do it. We've had nurses do it. It generally, unfortunately, just does not fit into my day-to-day schedule. So I'm not the one who does a lot of DBS adjustments. But back in the day, I have seen all of these things and I've heard of all of them, yes. Have I heard of emotional freedom technique? Tapping to alleviate anxiety? Nope, Donna, but I will read about it and I will figure out if that's something that's been, it sounds, if it alleviates or decreases anxiety, I guarantee it'll be beneficial in somebody. And so I'm not exactly familiar what it is, but I'll look into it for you. I was recently diagnosed with PSP. That's progressive supranuclear palsy. It's one of the Parkinson's plus conditions, amongst others. After 4 years of being diagnosed with Parkinson's, is that a common occurrence? I believe I have vascular Parkinsonism. Is that possible? And so the short answer to every question in that question is yes. This gets to a big point that I like to make is I am fairly conservative in who I actually label with the diagnosis of true Parkinson's disease. I am much more liberal with the diagnosis of Parkinsonism. Now, Parkinson's disease happens to be the most common cause of Parkinsonism, but Parkinsonism, for quick overview, because I know we're running out of time and I don't know how many more questions I got, but I'll talk quicker. Parkinsonism is the symptom. So anybody who comes in with tremors and stiffness and slowness of movement and balance problems has Parkinsonism. Parkinson's disease is idiopathic, which means we don't know why you get it. There's no obvious cause. And then everything else is typical. So I reserve it for people who are typical age of onset, typical presentation, typical progression, typical response to medicine. That might just be me. You may go down the street or go to a neurologist or go to a primary care doctor who is more liberal with the use of diagnosis of Parkinson's disease. I'm wrong too. Don't get me wrong. I have plenty of times diagnosed somebody with what I thought was true Parkinson's disease that turned into something different. The Parkinson's plus conditions are called that because initially, oftentimes, they look exactly like Parkinson's disease. They can present with tremors and stiffness and slowness of movement. But then you develop other symptoms. And so in PSP, it's typically difficulty with moving your eyeballs up and down and frequent falls, oftentimes in the backwards direction, a lot of axial rigidity or stiffness. And so it's not out of the, and I and myself have made this mistake. I have diagnosed somebody with Parkinson's disease only to a couple of years later, then think they were PSP or MSA or something else. That is not an uncommon occurrence. And likewise, a lot of patients, again, with the aging process comes vascular disease. And so vascular disease is anything that disrupts the tiny blood vessels that dive from the outside of your brain to the inside of your brain. And I can see this on an MRI. If we do an MRI and there's a lot of white changes or white spots, that's vascular disease. And that can also give you Parkinson's symptoms. So again, that wouldn't be Parkinson's disease, it would be a Parkinsonism. But the short answer to your question is yes, these are commonly mistaken and misdiagnosed or misunderstood. And then we go back later and change our diagnosis to something that we think makes more sense. Now, I'll tell you, the underlying treatment strategy is relatively the same. Same medicine, same harping on you about exercise, same physical therapy, same ideas. It's just that things don't go as planned. And that's where I like to use Parkinson's disease for a specific thing, because I have a much better understanding or idea of what to expect if I'm dealing with typical Parkinson's disease compared to one of the atypical things or Parkinsonisms. All right, I got a couple more questions. I'll run through them real quick. So don't throw any more on there in case you'll yell at me. Do patients with little tremor, stiffness, but predominantly balanced gait problems have a worse prognosis? For a while, we used to think that the answer to that was definitively yes. We thought that the rigid bradykinetic patients did worse than the tremor predominant patients, but there's been some questions to the validity of that too recently. We're not really sure that you can bank on the presenting symptoms being indicative or being for sure an indicator of who's going to do well or not. And so my answer to that now is no. We still kind of lean towards maybe if you're tremor predominant, things like DBS work a little bit better, maybe the medicines work a little bit better. But even though the old fashioned part of me wants to say yes, we always thought that the tremor people did better. I think there's been some data to suggest that that's not necessarily the case. At what point in therapy do I begin medicines? Well, that one I actually have a pretty good answer for. It's whenever we need to. What I mean by that is the medications are not fixing anything. They are not curing Parkinson's disease. They are not slowing it down. They are not altering the course. They are plain and simple symptom management. And so because of that fact, there's nothing that says you have to take a medicine. You don't really lose anything by waiting. It's not slowing it down. It's not altering the course. It's not disease modifying. Exercise might be. That's why I always tell people they need to exercise more, but the medicines definitively don't. And so we only need to put people on medicines when your symptoms bother you enough to take a medicine, because every medicine has a potential side effect. There's no such thing as a free medicine or a risk-free medicine. And so it's all about weighing out risks and benefits. So the potential benefit of the medicine has to outweigh the potential risk or side effect. And if your symptoms aren't bothering you, there's no way it's going to be that beneficial. And so my general question in my office is, How much is it bothering you? How much is it impacting your day-to-day life? Is it keeping you from doing things? And those are the questions that we use to dictate whether or not you need medicine. If the answer to those questions are no, it's not keeping you from doing things, it's a nuisance, but it's not bothering you that much, there is nothing that says I'm going to put you on a medicine. But if those symptoms are impacting your day-to-day life, then doing nothing is not a great choice. I have not heard of any results yet from the gene therapy trial they were working on here in Pittsburgh. There's been a few gene trials going on. There's one, the generation study, where they're looking at the genetics, but I know they've been looking at infusions of different genes. I haven't heard anything recently or an update about them. I know enrolling is tough in those kind of things, so it may take a while to actually get the data that they need. The American Academy of Neurology meeting, I believe, is next month. There may be some presentations there, but realistically, the International Movement Disorder Society meeting is in September in Philadelphia this year. There's probably more to come by then. And the last one, has any thought been given to continuous blood pressure monitoring to understand the effects of long-term carbidopa-levodopa use in Parkinson's, as on your heart and the development of hypotension? Being tired in the afternoon could be low blood pressure, especially if you're taking Cinemed every 3 hours. So the answer is yes. I don't know that they've ever done the continuous monitoring thing, but there's definitely been looks at blood pressure and how it is affected in Parkinson's disease, because again, your autonomic nervous system does become more impacted the longer that you have the disease, and your autonomic nervous system controls blood pressure. The use of levodopa does decrease your blood pressure. I don't know that anybody has ever looked at continuous monitoring or how it impacts dose to dose, but we know that it does lower blood pressure. And you're absolutely right. Tiredness is often a side effect or a symptom of low blood pressure. And so it could very well be that by the afternoon, people's blood pressures are going lower, especially because they're taking medicine so frequently as the disease progresses. And that could definitely be playing a role in that level. The short answer is I don't know that it would change anything that we do about it if we actually kept close control over kind of day in, day out, hour by hour measurements. Again, everything fluctuates fairly consistently and frequently throughout the day in people with Parkinson's disease. And so I don't know that that would help us diagnose or treat or change things, because we still don't have a better drug than carbidopa levodopa from a symptom standpoint. Could it affect us using other drugs like selegiline or things like that? Maybe. Or would I recommend DBS to see if we could lower medicines? I don't know. And so I don't know that anybody's actually looked at it. Yes, it could be playing a role. And I think it's just one of those things we have to keep in mind when we're adjusting medicines, or when we're dealing with people who are having a lot of lightheadedness or fatigue or tiredness, and see if there's anything we can do about it. All right, Casey. All right, Donna. I see your hand is up.
Because I heard about, if you are having low blood pressure spells during the day, they gave a warning that you could have high blood pressure overnight.
Well, and especially if you're on medicine for it. And so at the end of the day, blood pressure is positional. And so this will be quick. We're going to say quote unquote normal people. When you go from sitting to standing, you have receptors in your carotid artery here somewhere that recognize that the blood is going down to your legs and not up to your brain, and either increases your heart rate or increases your blood pressure to make sure you're feeding blood to your brain so you don't get lightheaded, dizzy, or pass out. That mechanism does not work as well in Parkinson's disease, particularly as the disease progresses. So you go from sitting to standing, that mechanism doesn't kick in, the blood pools in your legs, not your brain, you get lightheaded, you pass out. The medicines that we use artificially make that happen. And so they artificially increase that tone that increases your blood pressure and increases your heart rate and pumps blood to your brain, but particularly when you're standing. So if you were to go lay down after you take those medicines, it doesn't know that you're not standing up, and it still boosts your blood pressure perhaps too high. There is some automatic ability of your body to do that in terms of laying flat, making your blood pressure go up. And so that could be what you're referring to. But at the end of the day, that is what you see, especially with the medicines. And we do have to be careful about that. Now, I would argue that outside of people taking the medicines, I can't think of anybody offhand that I've seen where their blood pressure was going really low, and then all of a sudden later in the night they lay down and it goes through the roof. I mean, I'm sure that can happen. I can't remember that offhand, but usually we think about that supine hypertension in people that are taking the medicines.
When you say medicines, it's for Selegiline or what?
Not as much selegiline. I'm talking about midodrine, Florinef, droxidopa, mestinon, medicines that we use specifically to target blood pressure, low blood pressure.
But would you say that that is a disadvantage of carbidopa taking it long term, that you'll have this problem?
Yeah, because it amplifies what your disease already does, which is make your blood pressure go down.
Okay. Well, thank you, everyone.
Go ahead, Casey.
April 4th is our next Talk with the Doc. This recording will be on our YouTube channel by tomorrow. And please join us for our conference on Saturday, April 13th at the Hilton Garden Inn South Point, same location as last year. And Dr. Leichliter will be one of our expert panelists. We hope you can join us. Go to our website and you can register right from pfwpa.org or call me, I'll get you registered. Thank you, Dr. Leichliter. Thank you, everyone, for joining. Bye for now.
See you next time.
See you next time. Take care.